Our next presenter is Dr. Muralidhar RAMAPPA. He will be speaking on Mimickers of primary congenital glaucoma. Dr. Muralidhar is a senior member of our L.V. Prasad Eye Institute faculty team and head of rare eye diseases. He has been associated with the institute for more than 20 years. He did fellowship with L.V. Prasad Eye Institute, then in the faculty after that. Thank you, Murali.
Very good morning, sir. Thank you for kind introduction. Right. So, at outset, I would like to thank Dr. Mandal and AIOS for giving me this opportunity. And Debashish, in his presentation, he made my job very, very simple. So, my role is to, what are all the various mimickers of primary congenital glaucoma? How do we unravel? And we'll have a systematic approach to differentiate each one of them. Do not have any relevant financial disclosure. So why do we have a corneal edema? Presence of any abnormal material, it could be fluid, inflammatory debris, or a metabolic end product can give rise to corneal opacification because it does affect the corneal architecture and the regularity. If you look at this busy slide, so each of these cornea, the cloudy cornea, have a different shades as you go from the left to right. And one of the very classic, if you look at a bluish white corneal discoloration, one can easily assess and also see the entire architecture of the globe is distorted. So pretty easy, simple when we compare everything, but in a day-to-day practice, we tend to encounter certain borderline scenario where it may be difficult to distinguish. So when you see any child with shades of gray, and definitely the 6 to 8 causes will flag, and these DDs are not just limited. There are additional, right from fetal alcohol syndrome, Axenfeld-Rieger anomaly, and as Debashish pointed out, including the posterior segment abnormality like FEVR or ROP can actually give rise to corneal cloudy. And I skip in the interest of the time. He has covered very elaboratively the detailed evaluation, including the detailed history, consanguinity, because in the southern India, consanguinity is more prevalent. Hence, primary congenital glaucoma prevalence is much higher. And he also talked about, intraocular pressure assessment may be dicey in a certain scenario where we may have to rely on surrogate measures like a white-to-white diameter, axial length, anterior chamber depth, myopic shape, and so on. In addition to, the imaging, we do have a swept source imaging. I'm sure our next speaker, Professor Sushmita, will be elaborating on that. It is an invaluable tool when we don't have an access to UBM or a anesthesia facility. It can be done, in an OPD procedure. She would be detailing on the, the various techniques how we can acquire a pretty decent imaging in a child. So we'll start with the primary congenital glaucoma. As Debashish pointed out, they have a bluish corneal discoloration owing to presence of fluid in the corneal epithelium particularly. Unlike all other conditions, primary congenital glaucoma child will have an intense blepharospasm, photophobia, and lacrimation. That is a very classic triad. In addition, when we examine, not only the cornea is edematous, it is enlarged. There is a global enlargement owing to rise in intraocular pressure. We need to remember the pediatric eye is pliable in the first 3 years. It is amenable, it tends to distend with the rise in intraocular pressure. As it distends, there is also, stretching of the limbus and episcleral tissue, and like it gives a ophthalmic kind of a picture. At certain, when it crosses the physiological limit, DM can break and can give rise to HAP strain. And of course, intraocular pressure is rise, and we have to be factoring, so anesthesia, corneal edema, and so on before labeling it. So as I said, the white-to-white diameter, as he rightly said, in a newborn baby has a 10 millimeter, less than 10 millimeter. At 6 months, 10.5. at 1 year 11. So these are all the normal white to white, visible white to white diameter. Any aberrations which we have to take into consideration. One of the caveat is some of the microphthalmos or a microcornea, which also have a rise in intraocular pressure, so may have a normal corneal dimension. So one has to be carefully interpret such cases. So the next DD is congenital hereditary endothelial dystrophy. This is also autosomal recessive condition where you have a single gene, that SLC411 mutation, and it is also very prevalent in particularly southern India and also other Asian countries where parental consanguinity is very high. And CHED can actually have a varied spectrum. Some of these cases can have a mild innocuous disease where you can actually see the entire iris and a pupillary detail. It is not obscuring, including the decent retinoscopy and retinal view. So wherein we may not to do any intervention. As you go to the right, the severity increases, and these cases may benefit by doing endothelial keratoplasty. And lower panel showing this is a child who presented much later at the age of 16 years. Because of a chronic corneal edema, you could see a lot of secondary changes. The high resolution OCT also showing not only epithelial edema and also entire Bowman's anterior stroma is densely scarred. It has a degenerative panels. In such cases, we may have to resort to penetrating keratoplasty. Unlike PCG, if you look at carefully, there is no limbal stretching, horizontal white to white diameter is normal, and on a slit lamp when we evaluate, you don't see any epithelial bullous changes in a regular CHED, because even that suboptimal endothelium with the Descemet's membrane is still serving a very robust filter so that it doesn't manifest a corneal edema very early on. The next in line is posterior corneal dystrophy. This is a polymorphous dystrophy. You can see a beaten metal appearance. It's a very subtle. Mother of a child who was otherwise asymptomatic. It was an incidental finding. And grandfather has a much milder disease. Whereas the grandchildren, both of them have such a significant severe central warty corneal granularity. You can see here. And on an OCT, it can actually shows up. You have a sawtooth pattern, meaning it's not only endothelium is abnormal, they are metaplastic, they are multi-layered, and hence you have a sawtooth pattern that actually give rise to something called as a warty appearance. They generally have a vesicles, large vesicles. As the disease progresses, they coalesce to form a dense corneal opacification. And here distinctly this affects the central cornea. Peripheral cornea is relatively spared. Again, your limbus and other architecture are seemingly normal here, including intraocular pressure is normal. Again, in these cases, gonio is very, very important because this metaplastic layer which is proliferating on the corneal endothelium can extend onto the iris, can result in a secondary angle closure which is similar or analogous to what we see in a Heiss syndrome. Again, there are 4 distinct types of PPCD, and one of the PPCD where you have a call 8, so can also have a keratectasia. And generally they have 50% of them have a glaucoma. And since it is autosomal dominant, it's very, very important to examine parents as well. Third in category is a mucopolysaccharidosis, what we typically call lysosomal disorders. There are about 9 different types. And the type 2, that is a Hunter's, is the only one which doesn't involve the cornea, hence the transparency is not affected in the Hunter's. Again, it can manifest typically 6 months to 12, and you have a very clear-cut clinical signs. One cannot miss this when you examine a systemic feature. And they have again a very dense grayish corneal opacification. Hurler's is one of the most severe form. They tend to have a marked corneal opacification in comparison to the Mortax lami, which is much more common in Indian subcontinent. So they do have, in addition to normal intraocular operations to start with, they end up having a posterior segment abnormality that can irreversibly lead to the marked reduction in the vision. Also, it is always, we have to work in conjunction with a metabolic specialist and a pediatrician completely to unravel Now the good news is that if you detect very early on such children, we can send them for a hematopoietic stem cell transplantation. The child is under 2 years. Beyond 2 years, we can actually do something called as an enzyme replacement therapy. And some of these cases I have been following for the last 20 years. Those which had an enzyme replacement, they almost phenotypically look normal, healthy, children and adult, except, their cornea tend to, get opacified because cornea doesn't have a vascularity. So at this point in time, ERT doesn't help in reversing the corneal edema. And a very rare entity called as a congenital hereditary stromal dystrophy, unlike CHCD, here in a cornea is a normal in thickness. You can see a flaky white corneal opacification. It is again grayish white. I'll just take a couple of minutes, sir, with your permission. And intraocular pressure is normal. White to white diameter is seemingly okay. The pachymetry is around 450 to under 500 microns, where endothelium is normal here. In such cases, I do anterior lamellar keratoplasty. That gives rise to good outcome in such cases. Debashish has elaborated, although it is a rare condition, particularly in the Indian context, it is a much more prevalent. He talked about, Dr. Shubho will be, highlighting the genetics of it. I will not go into details of that. So we were talking about the classic clinical trial. So this is very, very important because, rest of the condition will not have this kind of, photophobia, lacrimation. That's easily can be detected. And the horizontal corneal diameter in the first 2 years is a marker of the disease. In our cohort, out of 2400, where Dr. Mandal has operated 1800 cases, only 12% of them had a persistent corneal edema that needed a corneal transplantation. As in this particular case, a newborn presented with a 60 was a pressure. If you look at all dimensions of eyeball, he is stretched, elongated. You also see a limbal stretching. And such cases can be systematically managed where we can take an intraocular pressure. This is one of the Mandal's case where following a trabeculectomy, the cornea is cleared. As I said, only 12% of the cases which have an infantile or intrauterine onset of PCG can have a corneal affliction. Otherwise, most of these cases, once you control intraocular pressure, the corneal edema reverses. And one other interesting thing what we've observed, so once you take care, if you have a robust IOP control, the cup tend to reverse. At this point in time, I don't have any data to show the fields also reverses. And there are many factors which are responsible for the poor outcome apart from a corneal edema. My threshold is a very high here. I do not operate unless the child has a significant visual morbidity, because PCG is a one nightmarish condition for a corneal specialist, because once you do corneal transplantation, although they don't lack a vascularity in the cornea, they tend to do well, but again intraocular pressure and a graft survival, they go hand in hand. And right from amblyopia, optic nerve head, eye astigmatism, they all can contribute to the poor outcome. So some of these cases systematically we can manage, end up having an extremely good outcome. So the key is good history and a detailed evaluation will help in unravel PCG from other mimickers. And we as an ophthalmologist and a glaucoma or a particularly cornea specialist play an important role in picking up some of the life-threatening metabolic conditions that need a prompt systemic evaluation, either by a molecular diagnostic facility or a metabolic specialist. It is always important to have those allied branches, so that helps in not only taking care of their vision and also the life of the child. And since many of them are, have a genetic origin, I think genetic counseling is very, very important. Maybe in a 2 to 3 generation, we should be able to eliminate if we really focus on such conditions. Thank you, Dr. Mandal, for
Thank you, Murali, for covering the topic in a very comprehensive